Andrew, are you ready to start?
Yes, I'm okay.
Perfect. So I suggest that we start. So thanks a lot for everyone to be with us today. Indeed, in the framework of the actuarial focus we have on the COVID-19, we have the pleasure today to have Andrew Cairns with us. So thanks a lot, Andrew, for being there. It's a pleasure and an honor to have you with us. So Andrew is a professor of financial mathematics at Heriot-Watt University, and obviously a well-known actuary on the longevity mortality topics. So we are very happy to have your view on COVID-19 today. So I let you the floor. And for sure, you can ask all the questions on the chat, or we will have more or less 20 minutes at the end of this presentation. So feel free. Thank you, Andrew.
Okay, so I'll thank you very much, first of all, for the invitation to speak today. It's a great pleasure and indeed a great honor to be able to present to your institute. So I'll try and start screen sharing now. So hopefully you can all see that. So before I get going with the main presentation, I want to also just acknowledge the people that I've been working with on this subject of COVID-19 mortality, and that's David Blake, Amy Kessler, and Marsha Kessler. So as you know, the topic is the impact of COVID-19 on higher age mortality, and so clearly the year of 2020, from my perspective as a researcher, has turned out to be very different from how I was anticipating 10 months ago. But it has certainly created some interesting statistical challenges for us. And I think perhaps these challenges and the problems that we will be looking at, that they will continue for many years to come, I think, as we begin to gather more data. So in terms of the agenda for this presentation, so I will start off first of all just by covering a little bit of the background and what the objectives are in our work. So what are we trying to do, and contrast it with what other people are looking at in terms of the epidemic. And then the main part of the presentation will be more or less split into two parts. So the first part will be looking at the demographics of the people who have been dying from COVID-19, and then thinking about how do these relate to or compare with all-cause mortality. So is the pattern of characteristics of the people that die, how do they look, what do they look like compared to all-cause mortality? And then also as part of this discussion, we'll be looking at the question about what do we know already at the current time in terms of infection rates, because this is something which is sort of not there when we are looking at, in general, looking at all-cause mortality. And then the second half of the presentation will be looking at the demographics of the surviving population. And we will look at this using a very simple model that we've developed, that we call the accelerated deaths model. And the purpose of this is to try to look at, amongst other things, to look at the adjusted post-pandemic life expectancy of the people who survive. And the people that survive include some people that were infected, but also a large proportion of the population who were not infected. So what does that population look like in terms of its mortality compared to the pre-pandemic population? And then at the end of the presentation, I will talk about the sort of secondary effects. So that will be looking at things like whether people that survive the being infected, do they have impairments and that sort of thing. Now, my presentation is going to be mostly based on English data, but many of the conclusions that we will come to will apply to other countries, such as France. The big differences perhaps between any two countries or indeed different regions are the infection rates. But if you look at people that are infected, then many of those differences will disappear. So in terms of background, I'm just going to pick up on a few news headlines that we've had over the last few months. So the first two are coming from the BBC News website. And so the headline is Coronavirus Death Rates Twice as High in Deprived Areas. And the second one on a radio program, a very senior medical professional was saying that COVID-19 exaggerates inequality whichever direction you turn. The National Health Service itself is again picking up on the idea of deprivation as being something which differentiates between different groups. That lays bare the ravages of COVID-19 on areas of high deprivation. And then outside of the UK, Health Europa, a title of an article, The Disproportionate Impact of COVID-19 on Senior Populations. So looking at the differences across age rather than by deprivation. And in some sense, a lot of these headlines, and you see them in other newspapers and things like that, is that they tend to very much pick up and almost exaggerate really what the differences are. And what we're interested in thinking about is this really distorting what is the real picture? And in particular, when we compare things with the all-cause mortality. So do we actually see a relatively similar picture in terms of differences between different groups, either by age or by deprivation or by different characteristics? So coming now to the objectives of our work and sort of building on that idea that I've put in, we want to think about what does the mixture of people who are dying from COVID, what does that look like? So that's in terms of the age profile, deprivation groups, socio-economic groups, how does it vary by region? Another question is the level of COVID-19 mortality inequality different from the level of all-cause mortality inequality that we would see in normal years, such as 2019. And then if we look ahead to look at the pandemic survivors, one of the key questions that we started off, so this is perhaps the starting point for our piece of research, was to think about this question. If you look at the people who survive, are they in some sense more healthy on average compared to the population before the pandemic that came along? And so will they have higher life expectancies in the absence of secondary effects such as long COVID, which I'll mention at the end of the presentation? Because then we want to then think about what are the longer term impacts of the pandemic, long COVID being one example, but then other things in terms of the prospects for future medical advances or cancer mortality, having had a year where cancer diagnosis is perhaps much lower than it would have been. Now, this chart it's adapted from a chart which was produced by a very famous UK statistician called David Spiegelhalter. And he's a professor in the communication of risk. So as part of that communication, he has a blog. And back in May, he produced a couple of charts which were similar to this, where he was comparing COVID mortality with all-cause mortality. And he was pointing out the striking resemblance between the curve of the death rates for the COVID mortality, a striking resemblance to the all-cause mortality curve. So what we have in this chart, and it's death rates that are on a logarithmic scale. So we have this sort of relatively linear shape for all-cause mortality. That's the Gompertz curve. And in this chart, we've got down at the bottom for females and males, we have the dots, which are representing the COVID mortality. And this is over the period March up to June of this year. And then we've got a couple of curves for all-cause mortality. And the dashed one is the usual all-cause mortality curve. But then, because what we're thinking about in this piece of work is linking COVID mortality to the underlying health of individuals in the population. So what we did was that we looked at all-cause mortality, but what we did was to strip out, to exclude deaths from external causes. So we are focusing in the solid curve in this chart on deaths that are due to the underlying health of the individuals in the population. And what you can see, in particular, when you look at the solid curve for all cause without external causes, is that there's a almost parallel relationship between the COVID mortality, the dots. It's almost parallel to the solid curve for the all-cause mortality, and that's even more so when you look at the males' mortality. So the takeaway from this is that as an initial conclusion is that the COVID death rates are by age are approximately proportional to all-cause mortality, excluding external causes. So if we just develop that a little bit, so what that graphic suggested to us was that the following way to look at COVID-19 mortality for a particular age. So this is what we're interested in, the COVID mortality. And it can be broken down into three components. So first of all, there is the all-cause mortality rate, which would be excluding the external causes. Then we multiply that by the infection rate. So that is the proportion of the population who are infected at any point during the pandemic. And then we have this balancing term, which we call relative frailty. Now, the first two terms are relatively straightforward, although the infection rate is quite difficult to measure. And then the relative frailty, what is that doing? Well, it is measuring the probability of death from COVID-19 if you are infected relative to the annual probability of death from all causes. And what the graphic that we had on the last slide, what that suggests is that the two of these terms, the infection rate multiplied by the relative frailty, that varies only by a small amount as we go from young ages up to high ages. So this is something that we have been looking at in a bit more detail, and we will be looking at more in the future as we get more data. Also in this equation up at the top, if we take a different pair of terms, and that is the all-cause mortality multiplied by the relative frailty, then what this is equal to something called the infection fatality rate. And it's a much talked about quantity, because this is what it's looking at the probability of death for an individual if that individual has become infected. And it is not to be confused with something else similar, which is called the case fatality rate, which is the probability of dying if you have had a positive test, which is a more easily measurable quantity, but it's something that is less stable over time because the amount of testing that we do has changed quite a lot over time, particularly in the early stages of the pandemic. Now, thinking about that and the infection fatality rate, one thing that we can do, and this is with more data coming in now about infection rates, is that there was a study which I'll talk about later on, but it identified that there was around about 6% of the population on average had been infected up to the middle or the end of August. So what I've done here is something very simple in this graphic, is I've made this very simple assumption that it's 6% across all ages rather than varying by age. And if I then think about scaling that 6% up to 100% infection rates, and that's the change from the black curve, which is what we have observed, going up to the red curve, which is how it would look like if we had 100% infection rates. And then it becomes slightly easier to compare in terms of a very crude approximation to the infection fatality rate. We can see from that the infection fatality rate is around about 1 or 2 times the all-cause death rate, which is the dot dashed line. So this is just a very simple starting point, and it's the starting point for a much more detailed analysis of the infection rate and the fatality rate and the relative frailty separately. Now we can generalize the concept of that equation that we were thinking about, because when we look at individuals who are all of a certain age, it might be 50 or 60 or 75, then within each cohort we still have varying levels of frailty, different levels of health. And we know this simply for example, if we look at the subgroup mortality. So in the UK we have deprivation groups, so we have deprived parts of the population and we have less deprived parts of the population. And we know that the least deprived group has much lower mortality than the most deprived groups. And part of the reason for that is that it's all down to individual risk factors, at least in part. So things like smoking, poor diet, less exercise. So in the most deprived groups, for example, we have a higher proportion who are smokers, and that leads to higher mortality. And certainly individual states of health will be different for that group compared to another group. So we see this variation in frailty at the subgroup level. What we also know is that when we're looking at COVID mortality is that people who die from COVID-19, that they tend to have underlying conditions or so-called comorbidities. So again, that is pointing to this point that if some people are more frail in terms of their health, then they are more likely to die. And if we think still in more scientific terms, so older people are at more risk of dying from COVID because they are more frail and also more likely to have comorbidities. And then also within this age group, a particular age group, people who have more comorbidities than the average for their age group, they are also more at risk. So this allows us to generalize our original equation that we put up a few slides back. So we're still interested in the COVID mortality rate, but it's now not just by age, but it's now by subgroup I. And so we have a COVID mortality rate for that group. And then we have an all-cause mortality rate, which depends on group and age. That's what I've just discussed. Then have an infection rate by group and age, and a relative frailty by group and age. And the group here could be characterized by a number of different things. It might be neighborhood deprivation, it might be by region, or it might be urban and rural, or it might be by ethnic group, or it might be a combination of these different things if you want to build up to it into a even larger number of groups, subgroups in the population.
Andrew, if I may
Yeah.
interrupt you, we have a reaction on the chat
Yeah.
from Jean-Michel, Pinton. Average rate of infection, whatever the age, is an ambitious hypothesis. What do you think?
That it is constant over all ages. Yes, so yes, I mean that is very an ambitious hypothesis. So I will look at it in more detail later on, and you will see that there is variation by age. So it's quite right to put that question, and I'll hopefully answer that a little bit later on.
Perfect, thank you.
Thank you. Now, in terms of our the hypothesis, so the hypothesis is now that...
Sorry, Andrew, another question.
Yeah.
Now it's great. People understood that they can ask questions through the chat. So, so from Junkie Way, so how did you identify these groups? What methods, K-means, ACP, etc.? How many groups? Thanks.
So on this slide, the groups are very much dependent on what data are available to us in terms of public data, and that is through the Office for National Statistics. So later on in the presentation, I'll look in particular at deprivation, where there are sort of good enough public statistics that we can do some more detailed analysis. Something that we are currently working on is a more detailed data set, which is maybe 7,000 or so different areas within the UK, and each area will have its own mixture of socio-economic and other characteristics. So that's very much work in progress, but I will be able to talk to you just a little bit later on about the deprivation as one particular characteristic. And then as we go on, and perhaps as we're able to get some more detailed data, perhaps at the individual level, then we may be able to investigate some of these things in just a bit more detail. And in particular, something I'll just mention in the next 1 or 2 slides is to think about whether the all-cause mortality is the best baseline for us to be looking at. So,
other questions?
Right.
So first one from Zakaria Raiti. Is use of medical treatment, medicine capacity a variable that could be considered in grouping?
Potentially, but it's not something that I certainly don't have access to that sort of data, and I certainly haven't looked at that, but that's very much an interesting suggestion, because in terms of, and that's something that would affect the relative frailty, because the infection rate is something that's given, all-cause mortality is something that's given, but then something that may change over time, and that's what we would hope, is that the treatments themselves will also improve, and so and then that would appear through this relative frailty, so which could be or I hope will be time dependent rather than just something that's fixed at the outset.
Clear. And another one, what about the variation of public actions in different countries or regions aimed to reduce SARS diffusion? So from Nicolas Maresco.
Mm-hmm. Okay, so well, that's certainly something explicitly we are not trying to model. So we're really leaving that particular type of mathematical modeling exercise to other people who are much more expert than I am on epidemic modeling. I mean, again, it's a very good question, because certainly one of the things we want to know is in the future, how much is the infection rate going to grow, because this is the total infections over the whole of the pandemic, and we want to know, rather than where are we now, we'd also like to know where might we be in 6 months or a year's time, and by that time, hopefully, vaccinations will have all taken their effect, and the pandemic will hopefully die out. But before then, we have to think about how to control. But I don't have any answers for that. That's for other people to look at.
Thank you.
Okay, so the hypothesis that we have is that the relative frailty within this equation is going to perhaps not vary very much certainly by age, so that was what we saw previously, but also now in addition by subgroup. And when I come to look at deprivation deciles, we will see that this hypothesis has some truth or validity to it. And what that means is that when we see differences in COVID-19 mortality between groups, then these differences are either going to be due to differences in the all-cause mortality rate, or differences due to different infection rates in different subgroups of the population. And then we can extend this a little bit. So this is much more of a conjecture than a sort of confident hypothesis, because we can also think about individuals. And then we might again still think that relative frailty might not vary much by age or by subgroup. Can we extend this to the level of the individual? But if that's the case, then we might want to, instead of having all-cause mortality, we might want to switch to using selected cause mortality rates. And the reason, or what we would be thinking there, is that the selected causes would be linked to those comorbidities which are believed to be linked to higher COVID-19 risk, things like obesity and then diabetes as a cause of death. However, an accurate analysis of this is going to take a lot more time to filter through, because we really need, first of all, individual health records to be able to analyze this, but we also need to be able to link those individual records to whether or not individuals were infected. And part of the challenge there is that the many people who are infected have maybe not had a test, and that test would therefore not be, if they're not tested, then there's nothing on their personal health records to say that they were infected at some point. Now, I'm going to move next to look at infection rates and just to say where we are within the UK. So here's our equation, and there's the infection rate within that equation. And early in the epidemic, the sort of evidence that we had about different infection rates, that was really down to looking at regional variation in death rates. So in particular, during the first wave of the pandemic, we saw that London had much higher death rates than other regions. And that would really come down to higher infection rates within London compared to outside of London. And then also we have information that's constantly getting updated now about at any point in time, how many people are infected and in different regions and at different ages. We then, towards the end of August, there was a study published by Imperial College where they did a random sample of the English population, around about 100,000 people, and they sent out antibody testing kits. And the results that came back were that on average, about 6% were carrying antibodies. And this is addressing the question that came up a few minutes ago. But the data also allow us to see, well, how much variation is there around that 6%, depending on the characteristics of the individuals. Now, the numbers that come out of that study are expressed in terms of odds ratios. And what that means is, so if you're looking at, say up down here, a figure of 2 times, what that 2 times means is that compared to the reference population, the chances of being infected are 2 times for this particular subgroup or people with this particular characteristic. So if we go back up, so if we look at males and females, well, it turns out that they had relatively similar infection rates. And then also, secondly, and I found this quite interesting as a conclusion, was that when you look at different deprivation quintiles, so the most deprived or the least deprived in the population, there was actually relatively little variation, whereas what you might have expected was that the most deprived, perhaps because of their work, the most deprived might have had higher infection rates, but that didn't seem to be the case in the antibody data. And then we could look at other characteristics where we do see more significant variations. So the age groups were certainly mentioned a few minutes ago, and in the first wave of the pandemic, so up to August, the youngest age group, as you might expect, had the highest infection rates, and with the reference group of 35 to 44. Above the higher ages, the variation was not quite so big. So the 1.4, that was the group that had the highest infection rate. London, not unexpected, that had the highest infection rate. And then, again, well known in terms of the news is that Blacks and Asians had much higher infection rates compared to the white population. And then again, unsurprising is that healthcare workers also have much higher infection rates. And then lastly, people who live in a large household are much more likely to get infected compared to people who live on their own. So in many cases, it's not surprising, but what these numbers are really they're just quantifying what we might have suspected.
Yes, if I may interrupt you, one question from Jean-Michel Pinton again. Are there any statistics relative to the level of earnings and also square meters per person?
Yeah, that's a very good question, but at the moment, no. And although the closest thing to income is through the deprivation quintiles, which are, is correlated with income, but not perfectly so. It would be certainly very nice to be able to look at that sort of analysis. There is also data where by sort of small regions with typically 10,000 people, and within those small areas, we do have data which we haven't analyzed yet, but within those areas we also do have information about the amount of personal space, shall we say, that these individuals have. So it might be by population density, but also there will be some information about the sort of sizes of households that people live in. So they're good questions, but at the moment we don't have concrete answers.
Thank you, Andrew. And another one from Rémi Gerbou. Did this study also consider the smoker status?
No, that's also a good question. I think, yes, I think so. This study, I can't remember the details, but I think what they found was that smokers were actually less likely to be infected compared to non-smokers. But of course, what you have to take into account is that all of these factors are interacting. And so smoking itself could be correlated with some of these other characteristics. So it is part of that study, but it was not as significant a factor as some of these other ones that we have here. Now, moving on from infection rates, I'm going to look next at deaths. And these are a few slides looking at age standardized mortality rates. So these are weighted averages of the single age death rates and based on a standard population. And in this chart, I'm looking at age standardized mortality rates by decile, so deprivation decile. So it's the least deprived group going up to the most deprived group. And in terms of the y-axis here, the ASMR is relative to decile 10. And by looking at it in relative terms, that allows us to compare all-cause mortality and COVID mortality. So, so in this chart, the blue bars are the COVID mortality and the gray bars are the all-cause ASMRs. So this is the same chart, but I've just added some more comments. Now, so this was the sort of headline results that came out of the Office for National Statistics in the United Kingdom. And if you look on the right-hand side, you can see that the blue bars for COVID are much higher than the gray bars for all-cause mortality. So the bars are going up generally because the most deprived groups have higher mortality rates compared to the least deprived. But the blue bars were going up at a much faster rate as we moved from left to right compared to the gray bars, particularly in the most deprived 3 groups. However, you have to be careful with this data because London in particular has had much higher infection rates, which I commented earlier on, but also London has much higher levels of deprivation compared to the average for England. And so what we reckoned was that this might distort the comparison of the ASMRs, because otherwise the conclusion is that the deprived groups have been disproportionately affected, and this is in comparison with the all-cause mortality. So what we did then was to dig around in the data that comes out of the Office for National Statistics, because they also publish ASMRs by region as well as ASMRs by deprivation. The combination of those 2 types of data allowed us to filter out the effect of region and to allow us to focus on the proper impact of deprivation on mortality. And that's what we have in this chart. So the gray bars are what we showed before for the COVID mortality without making any adjustment for regional variation. And then we can see on the right that the gray bars are much higher than the other bars. And then the red bars are the all-cause mortality, and then the gold bars are the ASMRs for COVID-19, but with an adjustment for regional variation.
Yes, one question from Thierry Aidecon. Are all causes, including external causes, in this chart?
Yes, so this chart does include the external causes, and that's because the data here are coming from the Office for National Statistics. Yeah.
Thank you.
But because it's looking at age standardized mortality, that the impact of the sort of accident hump for the younger ages is much diminished. Now, so what we observe here, having filtered out the regional effects, is that broadly speaking, the gold bars are very much more similar to the red bars for all-cause mortality. So in other words, that the mortality inequality that we see for all-cause mortality, that is somewhat similar to the inequality that we see for COVID mortality. So that conclusion that the deprived groups are disproportionately affected, in my mind, that's an exaggeration. What it is really doing is it is just highlighting existing differences in mortality between different groups. So if we summarize these previous slides, so we've got the Imperial College data where we looked at infection rates, and we found there that, or what they found was that different deprivation groups have similar infection rates. And then from the ASMRs, which we're looking at infection rate times relative frailty, the COVID mortality by deprivation seemed to be approximately proportional to all-cause mortality by deprivation. So what we infer from that is that relative frailty in this equation up at the top, that this is fairly constant across different deprivation groups.
And one question from Luis Portugal, is this constant over time? We are detecting in Portugal that the weekly proportion of COVID deaths is increasing. At this moment, weekly basis, COVID is the second cause of death.
Yes, so certainly we've been looking at in terms of where does COVID come in terms of the top 10 causes, and certainly at one point COVID was number one in that list by a very long way, and then it sort of dropped down and even dropped down out of the top 10 in England in the later part of the summer, and of course it's now going back up in the second wave of the pandemic. But when we look at this chart, it's a sort of slightly different thing. I mean, obviously from month to month, I mean, this is based on March to July. If you look at shorter periods, then again, there's a little bit of variation with it, but you certainly get a similar sort of chart in terms of a comparison of the all-cause versus COVID. And then a last point, just to mention before I go on to look at the survivors, is to think about data for other causes of death. So there was a paper published in Nature journal, and this is based on a very large data set with 17 million personal health records. And they were just looking at what were the characteristics of people who were dying from COVID compared to the survivors. And they were sort of confirming what people have been reading about over the previous months and since then, that there are particular comorbidities which are important in terms of increased risk. So things like obesity, diabetes, dementia, respiratory diseases, and so on. So all of this was essentially confirming that individual frailty is a big factor in terms of your individual risk, not just age, but also your comorbidities relative to the average for your age. So I'll move now to look at the survivors, and this is through the accelerated deaths model. And an accelerated death, first of all, so this is not the survivors, this is somebody who would have died in the future from other causes, but they have died earlier from COVID-19. And then for a given total number of deaths, so this is our approach to looking at this particular question for the survivors, is that we are taking the number of deaths as a given quantity. So we are not trying to model the course of the pandemic. We can look at it and see what has happened in the past, but we're not trying to predict what's going to happen in the second or the third wave of the pandemic. So we're really just taking up, sort of compressing all of the deaths into one number and then looking at the surviving population. And as a starting point, we're going to look at the sort of traditional actuarial curve of deaths. So if you just say look at a cohort that are currently aged 75, then this is effectively the sort of DX curve for mortality. What are the ages at death for that particular population, or for that cohort? So we start off at age 75, and then the curve of deaths gradually builds up, peaking in the late 80s, and then as the cohort dies off, the DX curve drops back down. Now, under this curve, in terms of all of the people that are dying at different ages in the future, what you can also see is that they're not all the same at the current point in time. Some people are less healthy now, some people are more healthy. And the people who are currently less healthy are more likely to feature on the left-hand side of this chart. And the people who are currently more healthy, they will be the people that will live for longer on average. We now introduce COVID-19 and say, well, what is the impact of COVID-19 on this curve of deaths? So there are two charts here. So in both charts, there's a sort of gray region at the top, and this is very much exaggerated so that you can see what's going on. The gray bit at the top are the people who would have died at a later age, but they've unfortunately died from COVID-19 during the current pandemic. And there are two versions here. So the left and the right-hand side, we have the same number of people out of this cohort who die from COVID. And the left-hand side, they're all chosen completely at random from the underlying population. Whereas on the right-hand side, the gray region is tilted much more towards the left-hand side of the chart. And it's really saying that the people who are currently less healthy, that they are much more likely to die from COVID compared to the people who are currently more healthy on the right-hand side. And as you might expect, the scenario B that I've painted on the right-hand side, that this is much more consistent with the empirical evidence that I've talked about already, that people who do have comorbidities are more likely to die if they get infected. So this leads us then to the very simple model that we developed. So if we look at a cohort that are currently aged X, say 75, and start off with 100,000 people, then DXT is the pre-COVID curve of deaths for year 1, year 2, year 3, or it could be month 1, month 2, month 3. And then out of each of these groups, so if you imagine each individual as having a sort of predefined label that they don't know about, which is when they will die in the future, then out of that DXT, a proportion of these will die from COVID rather than dying at time t in the future. And as a simple starting point, so because we really don't know what this proportion pi is in reality, we just decided we would make it just very simple, make it an exponential function. And we had to then just play around with the way that we parameterize that exponential function to make it up somehow reasonably meaningful in terms of the way that the parameters are set out. So there are two parameters. There's an alpha parameter and another parameter rho, and the alpha parameter is what we call amplitude. And this is what determines the proportion of the entire population, the cohort, who die from COVID. And then the second parameter rho, this is what we call the reach, and it is approximately, it's a very crude approximation, but you can think of this as being related to the years of life lost on average by those who die from COVID out of that whole cohort.
Andrew, one question from Luis
Yeah.
Portugal. What is the percentage of people 75 years up without comorbidities?
I don't know the answer to that, actually. That's a very good question, but I don't have an answer to that, unfortunately.
Thank you.
So this pair of plots are just showing how the reach parameter influences the shape of this gray region. So on the left, it's a short reach, but also with a high amplitude, just so that you can see the differences. Whereas if we have a larger value for the reach parameter, 4 rather than 2, then the gray region stretches out more into the sort of later years in this cohort's curve of deaths. Now, this model then allows us to quantify what is the so-called anti-selection effect, because one of the thoughts is that because of the link to comorbidities, what we're thinking is that the people who survive the pandemic, and in particular the people that survive having been infected, that these will be on average more healthy out of the whole population but before the pandemic came along. And so that's one of the things that we want to quantify. So just for example, for this particular chart, so the red region is the survivors, the gray is the ones who die, and then we have this big spike in mortality for the pandemic. Now, without a pandemic, the life expectancy would be 13.14 years. If you take the whole population, including those who do die from the pandemic, that comes down because some people die early. And then we have the residual population, the survivors, who have a higher life expectancy because of the selection effect, because they are a bit more healthy on average. But just keep in mind that this is a very much exaggerated scenario for illustration. So if we use some more realistic parameters, and in particular, more realistic means calibrating the model to, roughly speaking, the number of deaths that we are looking at in England from the COVID-19. So what we're looking at in this chart is the percentage increase in the life expectancy. So it is comparing the pre-COVID life expectancy and then looking at the life expectancy of the survivors. And then this is the percentage increase in the life expectancy. So if the life expectancy was 10 years and the increase is 1%, then 10 years goes up to 10.1 years. So in this chart, for the baseline scenario, where we have 80,000 deaths and medium value for the reach parameter, down at age 65, there's a really very small impact on the life expectancy. It increases by only 0.2%. It gradually increases with age, but it still doesn't get to particularly high levels when we get to the higher ages. And then what we're also showing here is just what is the impact on the life expectancy if we look at some other scenarios. So we have 50% extra deaths, then things get scaled up by about 50%. And then if you have a longer reach parameter in the model, the anti-selection effect becomes less strong. And so this curve gradually sort of shifts down, but more at the older ages. And I would also stress here, though, that although we're seeing the life expectancies going up, this is in the absence of other secondary effects. And that's what I'll talk about in just a moment. So what are these secondary effects? So we have to think about a lot of other things. And this is just a general discussion now, that there are no numbers really to talk about. So first of all, and this is an important point, is that we have to also be thinking about non-COVID illnesses. So for example, we know that many people who have been developing cancer, but they have had a much later diagnosis, or they've been missing regular cancer screening appointments because of the pandemic. It wasn't possible to go and get screened for something like breast cancer. So if you get a late cancer diagnosis, then your prospects for survival are going to be not so good. And so that might lead to higher cancer mortality in the future. And then if you are already ill, then it may be that you were getting a delay in your treatment for that particular illness. And again, that might have a negative impact on mortality. We then have to think about things like what is now being referred to as long COVID. So we have people who have been infected and they've recovered, but sometimes, in many cases, the symptoms of COVID persist for weeks or months, perhaps. What we are perhaps more interested in is the even longer term, more extreme versions of long COVID, long-term health impairments such as damage to your lungs or kidney impairments and things of that sort. And these are very much life-shortening impairments that we're focused on, rather than the having a more persistent call for other symptoms that persist for a few months. On the other hand, on the positive side, there may be some longer lasting impact in terms of the innovation that we get during the pandemic, so that might help to improve mortality rates in the future in a way that might not have happened otherwise, or they might come sooner. There are behavioral changes, positive and negative. So some people are sort of working at home. Some people are maybe getting more exercise than they used to, but other people are maybe not getting so much exercise, or they're maybe drinking more than they used to. So there are pluses and minuses there. We also have to think about the impact of increased long-term unemployment, and this is certainly looking very likely in the United Kingdom and in many other countries. I would imagine that there will be higher unemployment in the next few years, and that will then almost certainly lead to higher mortality rates amongst that particular group in the population. And then there are economic impacts in terms of future health spending and also research, and that might delay or slow down future mortality improvements. Now, some of the secondary effects that we've talked about, they might be observable in 2021 or even years beyond that when we look at cause of death data. So for example, we might see higher cancer death rates in 2021. On the other hand, we might see lower death rates from other diseases, so in particular respiratory diseases. And the reason for that is that people who are currently suffering from respiratory diseases, well, they might die early from COVID-19 because it takes out the people who are more frail, and that's the more healthy people that survive. And so we may see a sort of lowering in mortality from some of these causes of death. So just to round off now, a couple of slides with conclusions. So going back to the first part of the talk, the data are consistent with the observations that people with comorbidities are more likely to die if they get infected with COVID-19. And that's within a particular cohort, but also just by age. We also see a strong link between COVID-19 death rates and all-cause mortality. So that's by age, by deprivation, and potentially, although we need to spend more time looking at the data, potentially other groups as well. And then if infected, so if somebody does get infected, then key subgroups, these are our conclusions, key subgroups are not disproportionately affected relative to all-cause mortality. So I would stress again that the inequalities that we are seeing with COVID-19 are just emphasizing the existing inequalities that we see in all-cause mortality. And when we do see variation in mortality, as much as anything, it's because of variation in infection rates. And that's when we would see higher COVID-19 death rates if there's a subgroup that has much higher infection rates. And then lastly, the data has pointed us in the direction of the accelerated deaths model, where we made some very simple assumptions within that model, which we will gradually refine over the next year or so. And part of the modeling hypothesis is that the pandemic survivors will be healthier on average than the pre-pandemic population, but with the current scale of deaths from COVID-19 and in the absence of secondary effects, such as long COVID, the impact on the collective life expectancy of the survivors will be relatively small. But secondary effects could have a significant impact on life expectancies, but it's going to take us quite some time, I think, for us to be properly able to assess these impacts, if we are ever able to assess these impacts. So with that, thank you very much for listening, and I'll hand back to Marina.
Thank you. I have two other questions on the chat. So the first one from Jean-Michel Pinton. Is it that anti-selection is lower with older age? Is it not a paradox when one knows that young people are less dying from COVID?
Yes, that's a very interesting question. It's one that I don't yet have an answer to. The level of anti-selection is very closely linked in the model. It's closely linked to the reach parameter. And so at the moment, we've just made a guess at what that number might be. What we're going to do next is to try to see, well, what sort of data do we need in order to get a better estimate of what that reach parameter is. And the key thing is that when we look at the reach parameter, that if it's the larger the reach, the smaller the anti-selection effect. So it's not exactly answering the question, but that's the key to finding the answer to that. And it's something that, as I say, we will be looking at in the sort of coming months. And certainly indirectly, I think that we will be able to get some insight into that parameter, and we can do that by thinking about, within a particular cohort, how much variation is there in individual death rates. And we can get an idea of that by either looking at individual health records, but we can also indirectly see how much variation there is by looking at the variation between, say, deprivation deciles or between other groups. And that will help us to get to start to pin down what the reach parameter might actually be, and therefore the level of anti-selection.
Perfect. Another question from Timothée Fabre. Why the comparison between COVID-19 death rate and all-cause death rate on the same period can be relevant, since all-cause death rate is significantly biased in 2020 because of the influence of pandemic on people's behavior?
So I would need to check myself what, so that it depends on which chart you're looking at, where in terms of the all-cause. So the chart that I used at the very beginning, the all-cause mortality rate was for, I think, 2018. So that was the pre-pandemic mortality. The other chart and this was the one that came from the Office for National Statistics. I might be able to get that one back up. So in this chart, from the Office for National Statistics, the all-cause mortality, I think, was 2020 all-cause mortality. And so you are quite right that the data are in some way skewed by the fact that the all-cause mortality is distorted by the COVID mortality. But it's distorted in the same way for each of the 10 groups. So, so I mean, I would certainly be able to, but I don't think I have done, or I can't remember, if I was to reconstruct the gray bars, but using older data pre-COVID, things would look quite similar, but maybe just a little bit higher or lower, but not to the extent of variation that we see in this chart.
Clear. Another question from Luis Portugal. Don't you think a GLM model will help understand much better the conclusions presented?
Yes, and I mean, certainly within the medical literature, you can see, and I mentioned this particular paper here. So I think, for example, that this group were using a GLM or something similar to assess this database that's based on the individual health records. The one drawback I would see within this analysis that they've done is that as far as I know, they did not have information about individual infections with COVID-19 or not. So when you do the GLM and you're sort of analyzing the data in sort of various ways, and I think they have also included other factors that are socio-economic, but I've not mentioned them here. That would certainly have been done using a GLM, and it does certainly lend further insight into the analysis, and that's the sort of thing that we would be ourselves thinking about looking at if we are able to. And it's one of the things on my to-do list is to try to see if I can get some access to this data.
Clear. So you have a lot of messages to thank you. So and I'm really happy that the presentation is very interactive because we had a lot of other questions. So I'm conscious of time. Let's try to answer it, but in not by spending too much time for each of us. So from tuk tuk tuk. Wow, too many questions at the same time. I cannot follow. You're too fast. So from Etienne Israelevich, sorry if my pronunciation is not the right one. So what you describe is known as harvesting effect in epidemiologic. I did a study about harvesting effect in 2003 health wave, 200 deaths in summer 203, sorry, and 70% would have died in the year after. You want to comment?
Yes, so this is related to the point I made near the end, I think. So, so if I understand the concept of the harvesting effect, so because I've not heard that particular term before, but I think the idea is that a particular epidemic, I mean, it might be a flu epidemic, and we can see that in data, that a bad year for flu will, and this is my understanding of the word harvest, it will harvest the very frail people in the population. And then the next year, the people who are left are more healthy than they were at the beginning of the previous year. So yes, this is something that I will be certainly, and many other people will be looking for in the data for 2021, is whether there is a drop in deaths from other causes. And it's difficult to say how big that drop might be. And partly in my mind, it's related to the fact that there's only a certain proportion of the frail people who will get infected with COVID-19. And then the rest of them, thankfully, stay free from the disease. And so that limits how much of our benefit, sort of lowering, can happen in 2021.
Yeah. Another question from George Ochoa. What do you expect to be the impact on mortality of other factors that are a consequence of a pandemic, meaning impoverishment, healthcare depreciation, etc., in comparison to all-caused mortality?
I'm not sure I have a real answer to that. I mean, I think there will be multiple effects that we really almost can't imagine what some of them might be. But I mean, there will certainly be some examples, such as the sort of impacts of unemployment. There will also be impacts on health spending. But I'll maybe pass on in terms of trying to give a more detailed answer, because I'm not really expert in those sorts of directions.
Perfect. And another question from Cédric Delorme. We know at the moment that all causes mortality rate, including external causes and excluding COVID, have decreased, certainly due to control measures made by governments, for example, lockdown and consecutive reduction of accidental deaths. Is this reduction of overall mortality and consecutive disability much likely to have a long-term impact of population mortality?
Well, I'm not sure I can answer the question about what will happen in the future, but as a result of that. But certainly, that there are beneficial impacts in terms of lower mortality and from other causes, and that this is something that my own research group have been discussing from time to time, and our interpretations of the numbers are all changing all the time. And certainly some of the publications that come from the Office for National Statistics, they have these very nice charts which show deaths from particular causes, and then they compare this year versus the average for the previous 5 years. And 3 or 4 out of the top 7 or 8 causes of death, and that's excluding COVID, of course. 3 or 4 out of the top 10 have a significantly lower mortality rate this year compared to previous years. And just to pick one out, which is sort of somehow more consistent from month to month, is deaths from pneumonia. And that deaths from pneumonia in the middle of the year were about 50% of what they would normally be for the same month in previous years. And a potential conclusion from that is that staying at home has prevented people from exposure to the types of pathogens that will lead to pneumonia. And of course, there are lots of other examples. I mean, you have to think about, well, cause and effect, but that seems quite plausible in terms of the pneumonia as one particular example. And there may be other cases. We've also seen lower deaths from heart disease, which is maybe slightly more difficult. But it could be, and I'm guessing here, that working at home, at least for some people, might be less stressful, less likely to bring on a heart attack, although maybe for other people, staying at home in a big crowded household might increase stress levels and make it more likely to have a heart attack. But on average, it was resulting in lower deaths from ischemic heart disease.
Clear. So yes, we need to stop there, but we have many messages to thank you, Andrew. So
thank you very much.
it was a very clear and interactive presentation. So we were more than happy to have you.
Well, thank you. I mean, I have to say the questions from the audience have been extremely stimulating, and I'm very pleased that we've had such a good interaction during this session.
Excellent. So I suggest that we stop there and the presentation. There is a replay anyway, so happy to see it again. Thank you, Andrew. Thank you. Thanks to all. Bye bye.